Hello, everyone. Welcome to today's webinar. We are presenting on the laboratory drivers and barriers in the expanded carrier screening market. I am Bretta Coco, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more, please visit thermofisher.com/RH by NGS. We encourage you to participate today by submitting any questions you may have during the presentation in the Ask a Question box. So simply type them into the Ask a Question box and click Send, and we'll answer as many as we have time for at the end of the presentation. And if you experience any technical questions, or if you have any technical difficulties, you can utilize the Q&A box and we'll assist you directly. So I'd like to now welcome our speakers, Dr. Behar and Pamela Callum. Dr. Behar is the founder and CEO of Igentify, and Pamela is the founder and CEO of Tandem Genetics. For complete biographies on our speakers, please visit the Biography tab at the top of your screen. Dr. Behar, you may now begin your presentation.
Hello, everybody, and thank you first for this introduction, and moreover for the opportunity to participate in the Thermo Fisher Laboratory webinar. Today, I'm excited to share with you insights about preconception screening, and following me will be Pamela, who will speak about more aspects of the subject. With this, I would like first for you to read briefly the disclaimer, and then we can go right into the presentation. So, as we know, preconception screening remains one of the most important pillars of prevention medicine, particularly within the field of maternal fetal medicine and around reproductive health, of course. We do know that we are able to allow couples the choice to know about what are the potential risks that they might have while planning a family, and we know that we can allow them today to have informed consent decision regarding how to go forward. And we do know that today, as we are expanding our reach both to many more communities and as we increase the offering of preconception screening to what is usually referred to as expanded preconception screening, we do know that genetic tools are needed more than ever now to help us spread the opportunity to be involved in preconception screening, and we know that those genetic tools are needed across all the stakeholders of the process. First, the patients, then the providers, then the genetic counselors, and then the laboratories. If we're going to take a look at each of these stakeholders, we are going to have that they have different needs, and we need to address different issues that they might be interested in. First, patients should understand what is the purpose of preconception screening and how important it might be for their planning of pregnancy and pregnancies actually throughout their reproductive decision making. First and foremost, patients should know that carrier screening is for everybody. I often hear that patients say, but we know about no one in our family who has this disease, so why should I worry about it? And that is exactly where we should explain that we are actually looking for carriers who are not exhibiting any sign or symptom. They're only carrier of a particular disease, and maybe as a risk, if their reproductive partner also carry the same risk, then together they might be at a risk for a live birth of a kid with a disorder. Second, we need to explain to patients what type of diseases are being screened. So we have to explain to them about what is the inheritance mode called autosomal recessive or X-linked inheritance mode. We need to explain what is the meaning for their entire family in case a mutation is being found, what is the implication for the next generations, and maybe quite importantly, to also explain to them what are the treatment modalities. So we need to go into explanation of what is PGD, what is IVF, and so forth. Naturally, this is all meant to eventually allow patients to make an informed consent decision after properly understanding what they can gain, what is the potential treatment modalities. They can then consent and go ahead with the test. That is, of course, extremely important to have education about the potential today to prevent diseases. Next in line will be the providers. As you can understand, once we are dealing with mass population level preconception screening, we are discussing about a very high number of patients that might come for the test. And providers quite often have scant amount of times, and to put such a burden on providers to support and educate in conventional means, primarily meaning face-to-face or telemedicine opportunities that are existing, is simply incompatible with the time frame that providers have. And moreover, many of the providers that are going to give the first advice to the patients might not be genetic counselors. There might be nurses, or they might be, for example, OB-GYNs, and they sometimes are uncomfortable with genetics, and they would like to have assistance and see how we can help with genetic tools that are being developed as we are doing now, such as digital genetic aid and many different ways to augment the experience of patients and to educate them much better. Providers, of course, must have the help of genetic counselors. And genetic counselors today are overwhelmed. Their role in medicine became so important because now genetic counselors are not treating only preconception screening, only reproductive health issues. They also had to grow into oncogenetics, cardiogenetics, neurogenetics, pharmacogenetics, and so forth, which means that today we have globally only around 7,500 genetic counselors. We are speaking about genetic counselors have to advise patients a few times throughout one's lifetime, again, a reproductive health period, then maybe when we are maturing, maybe to be more around oncogenetics and so forth. And with only 7,500 genetic counselors worldwide, their task is really enormous. And to play the right role in the field of precision medicine, genetic counselors must have new tools that will allow them to expand their reach both to the patients and to the providers, supporting both the patients and the providers. More than this, it is also clear today that genetic counseling session is one of the longest medical sessions known to medicine, because it is often budgeted in between 45 to 90 minutes. Again, because patients has to gain knowledge about inheritance modes, treatment potential, how is preconception screening being done, what is the meaning to the family, and so on. So for that, new genetic tools are needed now, and certainly, as the slide says, more than ever. Eventually, labs play a pivotal role in the ability to deliver in timely manners the results of preconception screening, because sometimes patients are doing it during pregnancy. We, of course, recommend that it is going to be done before pregnancy, but we know from practice that sometimes patients learn about it only during the pregnancy. So not only that the laboratories have to be and have to operate in a very exact situation because they want to give the most correct and most elaborated lab results to the patients, they are working under time constraints because the pregnancy, of course, is progressing and you would like to have the results as early as we can. More than this, the labs have to be able to again return the results to the genetic counselors, to the providers, and to the patients so that everything is going to be clear, that there is going to be tools that make the workflow very efficient, the way they receive the information about the patients, and the way they return them to patients. And it is quite important because it is, for example, if we are dealing with couples who are making the test simultaneously, then we need to be able to return the results already explaining what is the meaning of the results for these particular reproductive partners. It is different, of course, had different individuals would have different reproductive partners, which means that the laboratories have to deal with fast way to deliver back results in a very robust way for high throughput as we are going toward expansion to more and more genes and more patients simultaneously. So these four stakeholders must play together. They must have clarity on which is the expanded preconception screening which is being offered, what is the list of genes which is ever growing as we know more and more about it, and how we deliver the information for patients who are found at risk, but equally important, for patients who are found to be at low risk. It is very important to realize that each couple need an explanation about the preconception results because we can never promise a healthy baby. We can categorize patients into low risk group, high risk group, and at risk groups. So even the low risk groups need to understand what other opportunities or what other possible screening tests are available to them. And that way we can get the needed education for the patients and the entire workflow between all stakeholders. With this, I would like to take you a little bit to speak about the evolution of carrier screening panels. This is a very important piece of understanding the difficulties and the magnitude of the ask from the healthcare providers, from the genetic counselors, and from the laboratories. Because we can quite clearly say that roughly 40 years ago, carrier screening started, but it evolved quite interestingly. For example, at the beginning, it was very ethnic specific, which means we can take a very concrete example. It was, for example, Tay-Sachs among a very defined group of people, the Ashkenazi Jewish people. That happened 40 years ago, and it was a completely different magnitude of a problem if you deal with one gene for one population, or if, as we are going to see, we are evolving now to have a plethora of genes being given in a concurrent mode to all the population. So ethnic specific was one. Second, it was a severe disease. So we naturally want to screen for diseases who have a severe outcome in case they are not being detected, such as, again, Tay-Sachs, cystic fibrosis, Bloom syndrome, Duchenne muscular dystrophy, and so forth. But as we got to know and to learn about our genome more and more, we also started to be able to identify diseases that might not be considered by all as severe diseases, and maybe some groups or in some cultures, screening for such diseases will not be welcomed. An example can be phenylketonuria, or maybe deafness, and so forth. So we started again with ethnic specific, with severe diseases, and now we are moving to a different level. We're going to see it shortly. Naturally, also, the first screening was targeted into high incident disorders that seized the attention of the medical community faster. But again, as we know more and more about our genome, then maybe we would like to screen for diseases that are very rare. And that is possessing both problem for the laboratories and certainly for the providers, because they now rely more on the help of genetic counselors, because maybe they know about Tay-Sachs and about cystic fibrosis, but they probably don't know about very rare neurological disorders, for example, that might affect only 25 individuals globally. So high incidence was yet another factor. Then what we used to do it in a sequential way, which probably one of the reproductive partners was the first to be screened, and then we were waiting for the result. And then when the results came in, then if the individual was found to be a carrier, then one would screen the reproductive partner and see if the reproductive partner has also a carrier state for the same disease. Again, we are looking, as you all know, for under the inheritance mode of autosomal recessive, we are looking for carrier state, which is identical between the two reproductive partners. And then if we find it, the couple will be at risk, which means that 25% of their offspring might be harboring the disease. So it was sequential. But naturally, as we screen for more and more disorders, we don't have time maybe to do it in a sequential way. So maybe we would like to move into other models, as we are going to see shortly. And also, it was always critical for genetic counselors or medical geneticists to explain to the patients about the test, what will it do for them, what can we identify, disclaim the limitations, and never, of course, promise a healthy kid. But these are all things that had to be explained to patients. And again, they had to be informed and to make a consent decision about whether they want to go ahead with the test or they don't want to go ahead with the test. And as you can see here, policy statements from the organizations that are leading the field have been exactly what we just described. Cystic fibrosis, Eastern European Jewish descent, ethnic specific, severe diseases of high incidence. But as we grew up more and more and learned more about abilities to screen for more genes, we started as the healthcare community to offer larger panels for our population, because we wanted to be able to screen for more. There were, first of all, changing demographies. So if previously we knew about a lot of couples being married within their community, now we have, of course, communities being merged and melted. And of course, the United States is a very, very a good example for this. So now we have to have knowledge about the mutations affecting this population and that population, and then merge them. Naturally, these changing demographies have been a very strong point for us to try thinking about offering everything for everybody and not be ethnic specific anymore. Second, we were able to find that mutations, named here founder mutations, that were usually associated with a given population are actually found in other population, albeit in lower level, but we still in lower incidence, but we still want to screen for them. Third, when we started to put on the laboratories plethora of mutations in many genes, they had to move into a more robust plex technologies, such as sequencing genes and hundreds of genes simultaneously. So once again, we are being pushed into more robust, and we need better and better tools to allow for this. The fact that patients are testing during ongoing pregnancy again mandate, as we said, rapid and comprehensive test. We have much more use today of assisted reproductive means, and there is more use of sperm and egg donors, and we might want to be able to combine a given individual with different sperm donors in a very fast way to allow the best a chance to reduce risk in the pregnancy. And naturally, as we became more and more familiar with our genome, also we went into a problem of wanting to go away again from the demographics, because in case of unknown or false reports of origin, we wanted to be able to give a test which is comprehensive and will cover any population worldwide. And indeed, we move that way. If you're going to look to today's current commentaries, then you can see that we now speak about expanded carrier screening in reproductive medicine. We speak about carrier screening at the age of genomic medicine. So today, we are speaking about pan-ethnic tests. One test fits all population. It is expanded screening because we moved from one disease initially, Tay-Sachs, to now screening sometimes hundreds of genes simultaneously. We have to deal with the issue of milder phenotypes, because some organizations, some groups might have a different preference of what to screen for. We are trying to move, because of the intensive labor that is involved in preconception screening, we are trying to move into concurrent reporting for patients, both to make it easy on the providers, on the genetic counselors, on the laboratories, but also to alleviate the tension from patients because they get the results immediately simultaneously. But one thing didn't change, which is quite important. We still need the genetic team to make sure that the patients are well informed and can give their consent to the test. Naturally, it is more complex. We need to explain more, but this principle remains intact about informed consent. And as you can see, we already see results coming from the world about the actual utility and how well expanded preconception screening is happening. Currently, this study here is being shown from the state of Israel, where preconception screening is now was offered for in the last 40 years, but now expanded preconception screening is becoming more and more popular, and actually will be reimbursed for all population starting next year. And the results have shown exactly what we were hoping to achieve, that we can identify more risk in more genes, more variants that might be affecting. And naturally, this study is also very clearly showing that we need newer tools to be able to expand the identification of couples at risk and to empower the understanding about our different reproductive choices. This particular is actually recommending that expanded preconception screening will be adopted by the Ministry of Health to be given as part of the health basket, and that was one of the reasons why it actually went in. With this, I want to thank you for listening. Be more than happy to receive questions afterwards, and I would like to pass the conversation to Pamela, who is going to show us more aspect about this important concept. Thank you very much.
Thank you. I appreciate the opportunity to participate in this educational webinar. And next steps are to elaborate on some of the clinical considerations given the evolution of these genetic testing platforms. As Dr. Behar introduced, as carrier screening has evolved, the patient education and counseling needs have also changed. And it's first important to consider who is performing these roles. Typically, the ordering physician takes on the responsibility of the pre-test counseling in many practices. And while carrier screening has expanded from these single gene and ethnic specific panels to large pan-ethnic panels for testing for hundreds of conditions, physicians have not gained any more time in their practice day to remain informed about the details of these tests or to counsel patients about all the possible results. There are some digital tools available to aid in patient education and support physicians both in their own education and in what they are communicating to their patients. And there are different practice guidelines available to also help provide guidance as to what is critical to convey to the patients. Some of the key items that are important to address are that this is a screening test and certainly not a diagnostic test that is going to prevent the birth of a child with a medical problem, but that the screening is intended to help identify some potential risks that may not otherwise be apparent in a family history, as Dr. Behar said, when patients communicate that there are no medical risks in their family. These are unknown risks that can arise due to being carriers for recessively inherited disorders and otherwise unknown in the family. The large testing panels now include many genes and variants that can reveal potential health risks to the individuals who are being tested themselves. So the reproductive patients are the ones who may be found to have some health information, and pretest counseling is very important to discuss this potential risk because most patients are having this testing to evaluate future risks to their future children, and they need to be aware that this information can also be revealed to them and can impact their reproductive plans or lead to additional assessments for themselves, depending on what's identified. Certainly something important to discuss with them as part of pre-test counseling. The other important consideration among many, but that I want to touch on today, is that partner testing and potentially the involvement of family members can be essential in order to aid in the interpretation of an individual patient's result. Without participation of these individuals, such as them being unavailable or even unwilling to have testing, it may not be possible to completely resolve a potential risk that is identified from a patient's result. And it's important that patients can be aware of these potential needs to involve other individuals at the time that they're having testing, because this can impact their decision to actually proceed with testing. Of course, in a clinical setting, management of the results and helping patients understand their information is definitely a large challenge in the carrier screening world these days. And starting from the left side of this slide, it's easiest to begin with those patients for whom no risk is identified from carrier screening. This will involve a significant number of individuals who are tested, where there's no excellent conditions or both partners are not found to carry variants for the same condition. Typically, post-test counseling has aimed to close the loop and ensure that these patients still understand the limitations of a negative result and that it is not indicating there is no risk to their children for health problems. But for many of other tests that are performed, patients are generally familiar with a no news is good news approach, meaning that they don't get a call when there is nothing to be concerned about or warranting further follow-up. In the world of genetic testing, we have traditionally had a different approach in ensuring that patients do receive one-on-one genetic counseling, but that ability to provide the one-on-one counseling is very taxing due to the limited number of clinicians and may not be within the scope of what laboratories can or are willing to provide to patients having carrier screening. So it's important to consider potentially new models for helping patients deal with these low-risk results. Patients who are required to schedule appointments and wait for their appointments to occur to essentially learn that there are no changes in their reproductive management based on the results, can have unsatisfactory patient experiences given those time points and appointments required, because it can delay their reproductive goals and their subsequent treatment approaches while they're waiting for this information that is not going to change their management. So figuring out how we use all this expanded testing, but also make it a good patient experience is something to consider for these low-risk patients. If we move over to the right-hand side of the screen, and if we think about solving for the low-risk patients in some creative ways, this will allow us to use scarce clinical resources and genetic counseling time and apply it to supporting patients with higher risk results that may be identified. If we look at the different types of patients who may have these genetic counseling needs for high risk results, we know that carrier screening methodologies can identify multiple variants in a gene for one patient, and it may not be possible to know whether those variants are on the same chromosome and the same copy of the gene, or are they inherited one from each parent, so in cis or trans. And this is where a reproductive risk may not be possible to understand without additional testing, such as whether a person has 2 copies of the SMN1 gene on one chromosome for spinal muscular atrophy, or if the 2 genes are on each copy of a person's chromosomes, in which case their children may not be at increased risk for spinal muscular atrophy. And in other cases, if a person does have 2 variants, the information may be important to their own potential health risks in trying to understand whether they are themselves at risk for a condition that may not yet be apparent or for which they're not yet expressing symptoms. In order to resolve these results, familial testing is often required to establish how these genetic variants are being transmitted through family members and resolve both the reproductive and the personal health risks. Other high-risk scenarios can include identification of X-linked variants or, of course, reproductive partners with variants for the same condition. The follow-up counseling required in these cases is often to discuss preimplantation genetic testing options and prenatal testing options, depending on where the patient is in their reproductive journey, and helping them make decisions for their family. This is certainly impacted by when the carrier screening is performed, and the earlier the testing is performed in their reproductive journey, the more options would be available to them. On the far right side of this slide here, I want to bring attention to the newest area of results management coming from multi-gene carrier screening panels. These panels often include hundreds of conditions for recessively inherited disorders, but our understanding of genetic disease and genetic risk is growing, and we are learning that individuals who are heterozygous for variants in some of these genes are at risk for other health problems themselves due to being carriers of just one variant in many of these genes. Notably, these patients, when they're having carrier screening in the first place, are not aiming to evaluate their own health risks when they have these tests. They're focused on their reproductive plans. So when these risks are identified, and these patients may be faced with personal health risk information, such as learning about increased risks for cancers, muscular and neurological disorders, this can certainly be disruptive to their reproductive plans. Patients receiving these results can benefit from consultations with trained genetic professionals rather than the primary ordering providers in an IVF or OBGYN setting. Ordering providers will also still have a role in managing this information typically. At minimum, it's important to ensure that these results are conveyed to the patient's primary healthcare providers, or that the patients are connected to other specialists for ongoing screening and management of these results, unrelated to their reproductive care. For some patients, they may also need access to mental health professionals to help them deal with these results. When presented with this information about their personal health risks, some patients may recognize symptoms in some of their family members for those same concerns, which can create complex dynamics in a reproductive setting, with patients grieving their own risks, symptoms in their family members, parents, and siblings, and as well as the risks to their unborn children. So definitely a need to aid in some follow-up with patients in managing these particular results. So again, as we transition from these single gene to multi-gene panels, the counseling has become more complex. Many healthcare providers who are familiar with the test themselves certainly are challenged with dealing with these next steps and managing the patient's treatment themselves. So when we think about the amount of information that patients are dealing with and how they're able to process it, it's an area to pause and reflect upon, because there's a lot of information coming at these patients. Carrier screening is only one of multiple tests that patients are being offered during their reproductive care, and this information can certainly be overwhelming for patients when increased risks are identified. Additionally, genetic counseling has traditionally been a non-directive practice in which patients are presented with information and options. Patients are then encouraged to select their course of action based on their own family's values and preferences. This is often an uncommon approach in healthcare in many settings and cultures, because a physician is often expected to have a more directive approach and guide the next steps in that patient's care. So the patient's understanding of the information, their ability to process that information and make decisions about moving forward can differ depending on the population being tested. And we can put some effort into trying to figure out the best balance and volume of information the patient is dealing with, along with their welfare in managing the information and need for support from their healthcare providers. It's important that as a healthcare community, we are aware of these issues and understand that there's opportunity to continue and learn and improve in these areas to figure out what the best needs are for the population being tested. So thank you for your time today attending this webinar. I'd like to now invite Dr. Behar back, and we will open it up for some questions.
Wonderful. Thank you so much to our speakers. I think that perspective from moving from single condition and ethnicity-based panels over to expanded and then bringing in that clinical discussion is very important. So we do have a few questions coming in, and I'll just remind the audience, if you haven't already submitted any questions, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many as we have time for. All right, so it looks like our first question, so this one we will direct towards Dr. Behar. Do most companies use a blend of technologies to assess variant status, such as NGS, microarray, et cetera?
Thank you for the question. So yes, the answer to this would be yes. And the reason is that different mechanisms, molecular mechanisms, might be the cause of different mutations. A very classic example will be point mutation, which is basically the change of one nucleotide with another, like C2T, which usually sequencing array would be very, very good at identifying. However, we have common diseases like Fragile X, who are actually the result of an expansion of an STR that is creating the actual variant, which is putting the individual at risk. So it is expansion of CCG, CCG, CCG. And in this case, sequencing or arrays will not be very useful, and therefore laboratories to give a comprehensive report on all the type of diseases that they might report on, will usually need a few different technologies, also sometimes for confirmation purposes. Doing the same thing in two different methods might, of course, increase the likelihood it is a true call. So the answer to this would be yes.
Great, thank you. All right, our second question coming in, I'll direct this towards Pamela. Do you think reimbursement for expanded panels will improve?
So I don't know what the labs are seeing as far as reimbursement. There certainly are some benefits providers that are covering carrier screening. And I wouldn't be surprised if it does improve, because I think the insurance providers would rather see patients be tested once versus having testing with each pregnancy, and have a larger panel performed perhaps from the beginning. Dr. Behar might have more input on what's being seen on the lab side.
Like you, I think that I hope that it will keep on being improved and improved, and certainly we need it. We don't have concrete information, but as healthcare organizations are making the recommendation to expand the tests and allow to more people, it is only logical that the payers will take this into consideration and increase their reimbursement.
That makes sense. Thank you both. All right, and then another question about the clinical side. When talking with patients, how important is it to explain technology? Does this come up, or do you refrain?
So in my experience, it depends on the patient's needs and what their ability is to understand all of the information about the testing. I think it's important to make sure they understand that more than one technology may be used, but that our ability to test for every possible type of mutation or through every approach is limited. So when explaining the testing, I think the counseling session is typically tailored to what the patient needs and can absorb. And the patients do provide some guidance to that about, they may ask additional questions and want to understand the technology further. But in most cases, I think the limitations of the testing and the technology are discussed versus the individual technologies themselves.
Understood. Yeah, and I think both of you brought up something to the effect of, no test is perfect. You're not necessarily going to get a healthy baby with this form of screening, but I think the limitations and the expanding on those points is perfect, but also tailoring it to the patient. That makes sense. All right, and then one more question. Do you think it's important to offer an array of panel sizes to patients? So we talked kind of at the beginning of the presentation, Dr. Behar, you mentioned or moving from ethnicity-based and single gene panels over to expanded panels. Do you think it's important to offer different panels to different patients?
So I would certainly want to hear Pamela's opinion on this as well, because she's seeing the patients on a daily basis. If you are going to ask me, I think that some flexibility is needed, but probably not too much. If we are anticipating patients to understand if they would like to have a gene panel of 300 genes or 301 genes, and the difference is a gene called AAPS, I'm just inventing something, then patients will usually be confused, and they will look for the guidance of the genetic counselor. They need to trust the healthcare provider. Having said so, it is clear that, for example, might be a situation in which the payer will give a reimbursement for X amount of genes, but the genetic counselor really thinks that the regulations maybe are a bit behind, and they would actually want to offer more genes. And then there might be another choice, which will involve some out-of-pocket expenses, which might have to be explained. So I would say that some flexibility is needed, but let's not expect from patient to know how many genes this year they would like to get. For this, the genetic counselors are working very hard to give the best they can. That would be my perspective. But Pamela, I wonder what you think.
Oh, I'm greatly in agreement. I don't think that having too many panels benefits anybody. In the United States, there are definitely regional differences with what the ordering physicians are comfortable with. And so there are some providers who want to stick with a very limited panel for common high-risk conditions and not include several hundred other conditions that are much more rare. And the patients themselves, I don't think, have the knowledge to really make independent decisions about those ranges of panel options that are out there. And so it really is guided by the physicians and what their preferences are. It's hard to say. I wouldn't offer too many options. I think it gets more confusing than beneficial in some cases.
That's a good answer. It's, keep it concise, but maybe offer a few if you have different populations. Wonderful. All right. Well, it looks like that's all of our questions for today. So I'm going to go on ahead and close this out. Thank you so much, Dr. Behar, and thank you to Pamela for speaking today and presenting. I think these are important topics. So thank you for your time today. We would also like to thank LabRoots and a shout out to Thermo Fisher for sponsoring. Before we go, I'd also like to thank the audience for joining us today and for their questions. Please submit afterwards or during the on-demand period, and then we can address those afterwards via the contact information that you provided at the time of registration. So this webcast can be viewed on demand. LabRoots will alert you replay, and we encourage you to share that email with your colleagues who have missed today's live event. So until next time, thank you again to our speakers and LabRoots and Thermo Fisher. Have a good rest of your day. Take care. Bye.
Thank you all.
Thank you.